So I think that segues very nicely into the next topic for discussion, which is athletic participation. As you all know, this is something that's discussed in great detail in long QT syndrome, as it is in many inherited cardiac conditions. And I think it's something that we wanted to look at much more carefully. I think there's an increasing awareness of, as very much as Adam was saying, as having a discussion with individuals, with the families about this particular issue. And so we wanted to present some of the research that's coming out now, some of the changes and in ways of people are thinking about this, not only from our institution, but also from other institutions. So I'm delighted to welcome Kristina Chambers. Kristina, many of you will have spoken to. She's been a member of the research team here at Boston Children's Hospital for the last 18 months or so, and has done a phenomenal job in putting this together, and also a phenomenal job in helping organize today's event, for which I'd like to thank her very much, because she's made a fantastic contribution. So without further ado, I'm going to hand over and let her discuss further about athletic participation. Kristina.
Hello, everybody. You received a lot of emails from me, so thank you for allowing me to be in your inboxes for the past 3 weeks. When I'm not emailing you, I am at Boston Children's. I work alongside with Dominic Abrams, and I'm looking at sports and long QT syndrome. And a lot of you I've spoken with personally, but over the past year, I've had the opportunity to speak with a lot of families about long QT syndrome, but specifically about your relationship with sports. And I've heard a lot of comments, and I've taken each of one of them, and I've listened to them, and I've categorized them, and I've pulled out the ones that were most salient to me. The first one was, he wants to play football like his older brother and father. Sports have been part of his whole life. Stopping was very difficult. And before the diagnosis, she was a star athlete who competed and won against the boys. Everybody expected her to go so far. And so what I gather from these comments are that you guys have very special relationship with sports. One, you want to play them. There's a social aspect to being able to play sports like everybody else in your classroom and to be part of a team like everybody else. And there's also the health aspect to it, being able to participate in sports in an organized fashion and to do so at a regular basis with your friends. And so I think it's important to go back and look at these sports restrictions. And so we'll do so in kind of 3 main ways. We'll go through and say, okay, well, where did these sports restrictions come from? And then we'll look at whether they were valid. Was there evidence supporting them or against them at the time? And what is it like now? And what does the future hold? What, after all of this, can I tell you about sports and long QT syndrome that you can go home and think about later, okay? So we'll talk about where did these restrictions come from. And in America, they are primarily guided by the 36th Bethesda Conference, which happened in April 2005. It was essentially a bunch of experts got together and said, well, let's provide a consensus opinion concerning sports participation in competitive sports for those with cardiovascular conditions like long QT syndrome. And this is what they came up for patients with long QT. They said, if a patient with long QT syndrome has either had an out-of-hospital cardiac arrest or had syncope, passing out, blacking out due to long QT syndrome, or if that patient has an abnormal QT interval value, and we told you earlier, for males, it's greater than 470 milliseconds. For females, it's greater than 480 milliseconds. Or if you have an ICD, they restricted all long QT patients to a class of 1A sports, and these are low-intensity sports that don't get your heart rate up too high, and this is all of them. Billiards, bowling, cricket, curling, golf, and riflery. And if you play those sports, most don't, right? So soccer's not on here. Lacrosse isn't on here. Swimming, basketball. These are the sports that kids really want to play because it's cool. So are they valid? You saw the restrictions. Now are they valid? Was there evidence at the time supporting them? And by and large, we see that there was very little evidence supporting the restrictions. But they were made by the physicians because they wanted to take care of you and your family. They were thinking about your best interests. But when you go into the paper themselves and pull out certain comments, you'll see I pulled out 2 that struck me. Few data exist from well-designed studies to determine whether a particular rhythm predisposes an athlete to symptoms that could cause injury. Yet, despite the lack of information, they decided we're going to come up with some firm conclusions to decide what kind of sports and under what conditions you can play these sports. So one of the doctors, Michael J. Ackerman, he's out of Mayo Clinic, he decided many years later in 2012 to test these restrictions, to test the validity of these sports restrictions in patients with long QT syndrome. And I'm just going to go through and tell you exactly what he did. He identified all of his long QT athletes. Then he did 2 to 3 days of follow-up of tests and treatments. And you guys are very familiar with these, the exercise stress tests, the EKGs. And then he brought the family together and said, let's talk about your test results and let's think about the risks and benefits. And then he decided that he let the family make that decision. So the mom, the dad, the athlete, he decided that that family now has all the information they need to make the decision for themselves. And then he followed up. There were 157 long QT athletes in his population who were regularly participating in competitive sports. After follow-up, 130 decided that they wanted to continue. So 27 decided that the risks were not worth the benefit of playing sports. 70 did so in accordance with Bethesda guidelines, and 60 did so against Bethesda guidelines. And out of all of these patients, there was one who had 2 sports-related cardiac events. So let's pull out who that one person was. He was a 9-year-old boy. He had prior history of cardiac arrest. He had a very high QT interval, so over 500 milliseconds. He received ICD shocks while warming up before a soccer game and while warming up before a baseball game. And when asked whether he took his beta blockers both times, he said no. So this was a non-compliant patient who had a very severe form of long QT syndrome who received treatment, appropriate treatment for his shocks. So what does that mean? Out of 650 years of athlete follow-up, so you take all of these people and follow up how long you've been following them for, there were 650 years worth of follow-up. One patient had an event. That translates to a less than 1% event rate, which is promising. So here at Boston Children's, we wanted to ask a very similar question. We wanted to know, out of all our patients with long QT syndrome who are on treatment, how many of them have cardiac arrests while participating in either recreational sports or in competitive sports? And this is what we did. We identified our recreational and competitive athletes on antiadrenergic treatment. So if you remember, these are your beta blockers, or if you've had a sympathectomy, we pulled you out and said, okay, you are a population that we're looking at. We classified these athletes based on the intensity of the sport, and I'll show you that later. And then we identified athletes exercising against our modified Bethesda guidelines. So we modified the Bethesda guidelines to include both recreational and competitive sports. Normally, the Bethesda guidelines are talking about competitive sports, but we thought it was important to include recreational sports as well. And then we looked to see if anybody had an event, either a syncopal episode or cardiac arrest, while playing sports, while on treatment. We had 176 patients who fell into that category of competitive athletes or recreational athletes. And then when we classified these athletes based on the intensity of the sport, we did so based on the Bethesda guidelines. And this is how they're normally set up. So there are 5 groups. Low, I showed you earlier, golf, bowling, billiards, all the way up to high-intensity sports, which include rowing, cycling, speed skating. You see, most of our patients fell into the moderate to high range. And that makes sense for us, right? These are sports that people want to play. They include soccer and basketball and American football, swimming, for instance. And most of our patients fell into that category. We identified athletes exercising against our modified Bethesda guidelines, of which 71% did so, 118 patients. And then we looked to see if anybody had a cardiac arrest or a syncopal episode while on treatment. We had 4 patients who did so. 1 patient was compliant with his medication, 1 was not, and 2 patients we don't know anything about their compliance. So in over 1,300 years of athlete follow-up, we had 4 patients who had an event. And what that, like Mayo, translates into a less than 1% event rate. So what does this mean for you? I've showed you all the data. Exactly what does this mean for you and what does the future hold? The data from Mayo Clinic and from Boston Children's is promising. And it mirrors the latest guidelines for sports participation in long QT syndrome. And this was released in 2013, and it says all long QT patients who wish to engage in competitive sports should be referred to a clinical expert for evaluation of risk. So I'm going to give you 2 things to take home today. One is seek out an expert in long QT syndrome and discuss your individual risk. Each of you is very different, and so your cardiologist, your electrophysiologist needs to talk to you and discuss your own individual risk. And then be prepared. Be vigilant with treatment compliance, and even consider purchasing an automatic external defibrillator to have while you're playing that particular sport.
Kristina, thank you so much. So we won't have any questions now because we're going to move straight on to Amy Walsh, who's our inherited arrhythmia specialist nurse here at Boston Children's. And again, I'm sure many of you know. And we're going to now talk immediately about automatic external defibrillators, then we can have some questions at the end. Amy.
Thank you. I wanted to start by asking how many people in this room actually have a personal AED at home that they carry around with you. So I'm guessing roughly about a quarter of you do. For those of you that don't, I'm sure you've wondered about purchasing that, and it comes up very frequently in our clinics. We get a lot of questions about that, enough so that Dr. Abrams thought it important enough to talk about today. So I'd like to share some experiences. I don't have all the answers. I've learned a lot of little facts, and perhaps you can grasp a pearl from what I'm about to talk about. One of the biggest questions is how do you obtain an AED? We spend a lot of time trying to go through insurance companies, and I have to be honest, it's a hit or miss whether they decide to approve it. It's a long process of gathering clinical information, obtaining prescriptions, letters of medical necessity, and it doesn't always work. Sometimes it does, and we're always proud when it does. You can purchase an AED on your own. You can go on the internet. You can buy them at Costco, I learned recently, and sometimes they have coupons. It's important to consider whether or not you actually really need one. In this day and age, pretty much everywhere you go, major sports arenas, shopping malls, or wherever your children will go, schools, they frequently do have them. And there are a lot of high schools where they won't let any varsity sports even happen unless there is a trainer and an AED on the field. And it's also interesting, most public officials, policemen, obviously EMTs, but firemen also will have them in their vehicles. So it's important to consider how close those people may be to your home or your children's school or wherever you may be traveling. The big question always is, how much does it cost? If you go through your insurance company or a distributor, they will bill your insurance company upwards of $3,600. I've done a large amount of research on the internet at work, no. And the average price really comes out to be about $1,000, give or take. Amazon, believe it or not, has the best prices. There is a website with many models to choose from called the AED Superstore. It's true. And I put Costco up there as well. I found a woman the other day who was saying that the best price she found was there, and they actually, in her little coupon booklet that came in the mail, there was a $300 off coupon. Another thing to consider when you're considering the cost is the accessories that go along with it. You need to purchase pads to go with the AED. Those will run you roughly $50, $60. You need to consider what size pads you need. Conveniently, anyone over 25 kilos or 55 pounds uses adult pads. That pretty much covers everyone in this room. The pediatric pads you may want to have around if your child obviously is younger or you have grandchildren, or some people just want a complete set. Batteries, you might want a spare battery. Those are expensive, another $125 to $180. And I added this in the other day. When considering paying for an AED, some people don't have an extra $1,000. And we had a recent rejection from an insurance company, and that insurance company called one of our providers and suggested that our patient use this website called GoFundMe.com. I looked at it. It's a very interesting website where people actually raise tens to hundreds of thousands of dollars for their medical treatment, mostly by using social media. I figure if I asked every one of my Facebook friends for $5, I would have covered a few AEDs. Just something to consider. I am a CPR instructor, and people ask me frequently what's the best model of AED. I have to be honest, they're all good. They're all just a little bit different, and all will give you specific instructions specific to that model. As you can see from this picture, these all look very different, but truthfully, they're all very easy to use, and they all do the same thing. They give very clear, concise messages. I'll play one for you now. You'll see how simple it actually is.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light, analyzing heart rhythm. Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock now. Press the orange button now. Shock delivered. Paused. Begin CPR.
Anybody not understand what they're instructing you to do? Here are a few different models that operate differently. This is a model that's easy. It turns itself on the minute you lift up the handle. This is a model where you choose the size of your pads based on the weight of the patient, whether it's adult or child, and the machine will automatically adjust the energy accordingly. This one's a little more advanced model where you can actually see the EKG, which is incredibly helpful to those of us that are healthcare providers. I suspect in the lay public it might stress you out a little more than be helpful. And what other things do you need to consider? So you purchase an AED and you have it at home and you put it in the closet, and hopefully it sits in your closet for a lifetime. But you do need to take it out periodically, check that the battery still works, check that the pads haven't expired. You really need to be vigilant about keeping the machine operable. When you're purchasing it, like I said, we talked already about choosing the appropriate pad size. And you also, if you're going to have a machine, you want to make sure you know how to use it. So I clearly would recommend taking a CPR or an AED class. They have some great programs through the American Heart Association now. I actually have samples of one in the back. For about $40, less than that even. You can get a DVD and a little mannequin that you actually blow up, and you can watch the DVD and practice while watching. And the research shows that people learn just as easily as sitting in a traditional class. All this being said, we're considering a new study looking at the psychological impact of personal AEDs versus the practical health benefit. Now, that's all up here in our heads still, but ideally, if we get this study designed, we would be able to provide the AEDs for the study participants, and if you think for any reason that would be something you might be interested, let me know, and when we actually get it out on paper, we're happy to contact you. And as always, if you have any questions about any of this, we are all here to help, and I'm happy to provide any information we may have. Thank you.
Thank you very much. Any questions for Kristina or Amy?
Okay. So our daughter was diagnosed around 7 years old, and at that time she was in a competitive swimming program, so we took her out. What is it about swimming? Is it merely the fact that if an event happens in the water, you're worse off than if you were, on land? Or is there something about the temperature of the water or some reflex?
So I think that there's a lot of issues related to swimming, and swimming sort of constantly crops up in the early days of long QT syndrome. that events are occurring during swimming. And I think one of the more credible answers is exactly what you said. It says if you lose consciousness in a swimming pool, it's a much more dangerous environment than it is on a soccer pitch. There is the phenomenon of the dive reflex.
Yeah, I mean, but you become bradycardic though, right, with that?
Yeah,
right?
and but it's potentially as your heart rate speeds up again.
Okay.
So that's one of the theory. Obviously, it's never been sort of formally tested, but certainly that's one of the other theories that relates to that.
Okay.
So swimming is still something that is causes concern, particularly with long QT1. But again, it's something that's constantly being looked at and constantly being revised based on evidence in terms of patients who are treated, etc.
Thank you.
Pleasure. Yes, sir.
A question on research, and one of the things that you can do, you said earlier, would be to participate in research. And I'm wondering with all the privacy laws and stuff, are you having difficulty getting participants? And if you're interested in helping out, how do people get hold of us to get started?
That's a very good question. So I think from my personal experience, having worked with families over the last 10, 12 years who have inherited cardiac conditions, people are always incredibly willing and generous with their time, with their DNA, whatever it may be, to be involved in research. And usually patients with inherited cardiac conditions are very informed and want to know more. What's out there for us? What can we do? How can we help? How can we find out more? And I think that, one of the classic examples is this sports situation. There was a bit of a blanket rule based on evidence that we had at the time, or the knowledge that we had at the time. And it became a bit of a doctor knows best. And I totally applaud Mike Ackerman at the Mayo Clinic, who said, this isn't doctor knows best, this is much more of a collaboration between physician and patients. And that's how it should be. And we're here to give you the information in a clear and concise fashion and allow you to make judgments with our help and to come up with a formative plan, much as Adam was alluding to earlier. And a lot of that is research because, Mike Ackerman, when he started that, he didn't know what was going to happen. Were there going to be a high rate of events? He suspected not, and a lot of us suspected not, because we just weren't seeing patients coming back with problems during exercise. It was doing the washing up. It was, we just weren't seeing that. And if you look very carefully through the literature, particularly at long QT1, where exercise is considered to be more of a risk, the word exercise was never mentioned in any of the big studies. And, again, as we're seeing more and more people identified in families who may have been, didn't know they had the condition. I've looked after international athletes who ran track, did everything they should never, ever have done according to these guidelines. And they say, hey, I'm fine. Then I've never had a problem. So I think we now need evidence to do that. And we need your help to get the evidence, I guess, is the way I would see it. So I think we, when we're designing studies, we always try and reach out to as many patients as we can to say, who would be interested in participating in this. That's a long-winded answer to your question, but I hope it answers it.
Is there like a central clearinghouse where you can give somebody your name and say, if I do this study or find a study, can you get a hold of you, or is it just
I think there's different ways to do it. Certainly there's organizations like SADS, who you may be aware of. They often have different centers who are running different studies on their website that people may be interested in finding out more about, and a piece of contact information. Certainly here at Boston Children's, we would send out letters to all patients who we thought were suitable for any particular study and say, this is what we're doing. If you'd like to find out more, give us a call. And obviously there's utterly no obligation. So that's how we do it. We also have a website where, we will, I hope on our sort of Facebook page as everything's happening. That's the way it's going these days. We do, we will be advertising certain studies that we're doing. As we're very interested in the impact of AEDs on many levels. So that is something that we'll be doing, and we will be advertising that on the website and saying, if you're interested, here's the number to give us a call.
So with these AEDs, how long do you have to actually get it onto your kid and shock them if they have an event?
Well, the sooner the better. I mean, there's this concept of the golden period of time when we know from many, many studies that the sooner the device is applied and the rhythm is restored to normal, the heart starts beating, the brain starts perfusing as do all the other organs. So really the sooner the better is the honest answer to that. There's no sort of point at which we wouldn't advocate strongly performing all the resuscitation. But obviously, the sooner that can happen, the better the outcome. Yeah.
Sorry, the CPR instructor in me. You have CPR to maintain circulation to the brain and important parts of the body before you get that AED on. So just a little push to make sure you updated your skills.
Not to skip a class, let's certainly set up for compression, but it's compression only still, right? There's no breathing anymore on the CPR. The last time we did it 2 years ago.
There are compression-only classes. Yes, absolutely. But no, we still teach healthcare professionals mouth to mouth as well as compressions, and if it was your child, it may be something you're interested in. But the research shows that the compression-only CPR is still very good.
I just wanted to say one thing. Children's was very helpful to our family as we went from elementary to middle school to high school, is helping the child's school district understand that as part of the 504 accommodation plan, they would be required to have ample AED access throughout the campus. So as your kids get older and they start going to bigger and bigger schools, they may only have one AED that wouldn't be accessible on a football field. And you guys were great at collaborating with the school districts to help them sort of have an adequate coverage throughout the buildings. And they were actually very and largely thankful to, because nurses have been asking for that kind of coverage for years, and it enabled the schools to properly fund that. So I just want to mention that to parents to reach out with your helpful letters.
That's great to hear, and I think it's very good to know that many schools now will have AEDs. And I was speaking to a patient recently, a parent of a patient recently, who went to her school telling them that she really thought they ought to get an AED, and they already had 6, and here's where they are around the school. So I think it's always good to ask your school what they have, and you may be very pleasantly surprised this is something they've already taken care of. The evidence from Wisconsin shows that you're just as likely to save grandfather in the stand who gets a bit overexcited during the football game as you are the 15-year-old kid on the pitch, but hey, a life saved is a life saved. Question there.
The study you talked about that Ackerman did and the work that you just presented is a pretty substantial change from the 2005 guidelines. So is there anything that's being done with those studies to reissue the 2005 guidelines, or are future studies being done? But it seems like it pretty much makes those archaic.
I think a lot of things are heading away from those guidelines, and as I said, those were sort of based on the best evidence the best judgment that was available at the time. And Mike Ackerman's the first to stand up and say, I was on that panel, and he felt that's the worst thing we have to do, is restrict kids from sport by and large. So I think they are moving away. Those are the latest Heart Rhythm Society guidelines, which is slightly different, but really now say it's got to be a much more detailed conversation rather than just a blanket ban. I don't know when the next Bethesda guidelines will be rewritten, but I think that there will be moves away from them on a more condition-specific basis as well. But I think the evidence is all starting, and this is now evidence, is all starting to mount away from that. So hopefully that will be reflected in the guidelines soon. Caitlin.
My question is about the AEDs themselves. So say your child faints and you can't find quickly a pulse, and you start to panic and you get the thing going. Is it ever possible that they don't need it and they're going to get shocked, and that's going to be bad? It won't shock? Okay.
They don't need it, it won't shock.
Okay, so that's why it says, like, don't touch the body, and it does that.
Exactly.
Okay.
And it'll tell you if you're touching the body and if you analyze properly, it will remind you to stop.
Good.
Good. Well, thank you very much. That was an excellent session. Amy, Kristina, thank you very much indeed.